I'd like to call to order the Health and Human Services Committee for June 19th at 1 o'clock. Can we have a roll call, please?
Calling the roll, Ms. Conwell.
Here.
Mr. Jones. Mr. Jones is absent at the moment. Ms. Brown.
Here.
Mr. Miller.
Here.
Ms. Stevens. Ms. Stevens is absent at the moment. We have a quorum. Also, let the record reflect that Councilman Brady is also in attendance.
All right, Cheryl did call and she's running late. Is there anyone signed in for public comment?
No, Madam Chair, no one is signed in.
All right, can we have an approval of the minutes for the May 22nd?
I so move.
Moved and seconded. All in favor say aye.
Aye.
Minutes have been approved. No matters are referred to the committee today. We have a presentation by our famous Adams Board, a budget update, and then we'll have a discussion later. For the Adams Board presentation, you're welcome to stay, but you can go on about your merry way. It's just internal stuff for the discussion later. Thank you. Who is presenting today?
Two, then? Did you? No, I will not. All right. Well, thank you very much for having us here today. My name is Scott Osicki. I'm the Chief Executive Officer of the Adams Board of Cuyahoga County. And, just want to start out with that we are grateful that we...
To overdose on purpose, I feel like was like my rock bottom, but I wasn't even, it wasn't
Did I
like
hit it?
aha.
I was like, who is that?
To where it was my rock
You're like, where did that come from, right?
Someone's joined us.
My bank, whatever.
It's not that video either.
Oh, it's not? Okay. All right, so once again, thank you. And first of all, we're very, very grateful that we understand that we will not be receiving a reduction in the 20 and 21 budget. So we just want to let everybody know that we are thankful for that. However, in light of the increased needs in our community, we have to ask for consideration for additional funding for the Adams Board. So just in case you don't know, that I want to let you know what the Adams Board is and what our role is in the community. So the Adams Board, we're responsible for the planning, funding, and monitoring of all public mental health, addiction, treatment, recovery support services in Cuyahoga County. We're one of 50 boards throughout the state, and we are designated through the Ohio Revised Code to ensure that the services of our area meet the needs of our residents. We're a quasi-independent part of Cuyahoga County government, and we're governed by an 18-member volunteer board. And I have some board members here with me today. And we have our board president, Reverend Ben Golston. Is there. And we have one of our vice chairs, Dr. Robert Fowler. Okay. So on those members, that 10 of them are appointed by the county and 8 are appointed by the Alcohol, Drug Addiction, and Mental Health Services of Ohio, the Ohio Department. I also want to introduce the executive team that's here with me today. I have Dr. Leslie Koblenz. She is our Chief Clinical Officer Consultant. I have Maggie Tolbert, who is a psychiatric nurse, and she is our Assistant Chief Clinical Officer. I have Felicia Harrison. She is our Chief Financial Officer. I have Tammy Fisher. She is our Chief Administrative Officer. I have Curtis Couch, which he's got a long title, which is Chief Data. Tell me what it is, Curtis. Chief Technology Data Analytics Officer. And then we also have Ms. Linda Lamp, who is the executive assistant to the board and also to me. So it's important to realize that we don't provide direct services, but what we do is contract with 65 provider agencies to deliver the treatment and recovery support services to the residents of Cuyahoga County. So we're designated through the Ohio Revised Code also as the hub for the opioid response in our community. And that means that we're co-chairs of the Cuyahoga County Opioid Task Force in partnership with the Cuyahoga County Board of Health. We're also an executive member of the U.S. District Attorney's Heroin and Opiate Task Force. And we serve as lead agency for the Cuyahoga County Suicide Prevention Coalition, executive member of the Stepping Up Initiative, and are members of other collaborations, including the Community-Based Correctional Facility, Family and Children First Council, Cuyahoga County Problem Gambling Coalition, and there's just many more things that we are. So I wanted to let you know that we are very active within the community. So what we fund, so what we do is we pay for services for people who are not covered by insurance or Medicaid, or who are in the process of applying for the benefits. And we also fund recovery support services that are not covered by insurance. On the slide you see here, you see that there are some, you see some of these services such as crisis stabilization, housing, prevention, education, information referral, detox, client rights, and even transportation for folks to get to and from their appointments. So regarding the people that we serve about approximately 100,000 adults and children with the recovery treatment services. We also serve another approximate 23,000 people and children with prevention services as well. And when it comes to planning for behavioral health care in Cuyahoga County, we really look at the needs of what the community wants. And that's why our volunteer board members are there to represent the folks in the community. So what we did when we were looking at calendar year 19, we were setting up our priorities. So in calendar year 18, we met with various stakeholders. We met with clients, we met with families, board members, providers, and other community partners via in-person meetings, as well as we also had web-based town halls. It was the first time that we've done that to make sure that people had an opportunity to participate in it, to determine what the priorities were for the community. So the funding priorities were chosen based on the need and the ability to support a recovery-oriented, person-centered continuum of care for persons living with mental health conditions as well as addictions. And as you can see on these next two slides, our funding priorities for calendar year 2019 include the following. They weren't in any particular order. They were all considered to be important. One was high-quality housing, expanded crisis services for children and adults, 24/7 access to mental health and addiction treatment services, prevention and early intervention programs, such as traditional ways of doing that with school-based early childhood mental health, various campaigns and education efforts, and also faith-based programming. We also thought that peer support was very important, employment programs, inpatient and ambulatory detox services, medication-assisted treatment for opioid use disorder, piloting innovative techniques and programs, and then also transportation for clients. So this priority setting process was very helpful in understanding essentials and being successful for behavioral health care treatment and recovery, so people be able to attain recovery as well as stay in that. So before I continue to talk about our budget, once again, I want to thank you that we're not anticipating any cuts for 20 and 21. But during the process of determining funding for mental health and addiction treatment and recovery supports in 19, the Adams Board, we faced nearly a $4 million shortfall on top of a $6 million shortfall from calendar year 18. That brings us to our budget. So the dollar amounts on this page include funding from the Cuyahoga County Health and Human Services Levy, which is the $39 million, as well as other funding from federal and state grants, as well as pass-through dollars that we have. So you can see in calendar year 17, our budget was $73 million. In 18, it was $67 million, and in 2019, it was $64 million. And all the while, our funding from the county remained the same at the $39 million. And this left us with a compounded deficit since 2017 of $9 million.
May I ask a question?
Yes, go ahead.
My question is what your projected year-end balances for 2019.
The year-end balance should be, what we would have is we would have carryover dollars, but the carryover dollars are only for grants that we received from the federal government that run on a federal fiscal year rather than our calendar year. But everything else is anticipated to be spent.
So you're basically expecting to have no reserves at the end of this year, that everything that any cash on hand would be money that's obligated for.
Yes, that's what we're anticipating, yes.
Okay.
So why the shortfalls, right? So the loss of the $1.5 million in local one-time funding we had in 17 to combat the opiate crisis. And that's where we received some money from the city, some money from the county, as well as the Adams Board took $1 million out of its reserves to provide additional beds, treatment beds, recovery beds, as well as detox facilities. And then then we used $4.5 million in reserves to cover deficits from the reduced state and federal budget for mental health services since calendar year 15. And then the loss of nearly $4 million was due to the ending of the 1915A Medicaid waiver for child treatment, wraparound, and service coordination in state fiscal year 19. and then the stagnant funding from the Cuyahoga County Health and Human Services levy, which actually goes back to calendar year 14, that we have not had an increase in our Health and Human Services funding. So what did we do? How did we respond to these shortfalls? So because of the flat funding from the county, depleted reserves, and a desire to maintain services to combat the opiate crisis, the board, we really had to make some difficult decisions to respond to the shortfalls. Under the previous administration, the Adams Board defunded $1.8 million in 20 pilot and other targeted programs that were beneficial and designed to serve a limited number of clients. So therefore, we had to stop that. Then in calendar year 19, the board reduced funding for nearly all of our non-priority programs and providers. So in response to the loss of the $4 million due to the 1915A Medicaid waiver, which was all for children's services, we had to reduce funding for prevention in the schools by 25% and other children's services by 10%. Most of the other programs, with the exception of the ones with our new priorities, we reduced by 10%. In calendar year 19, $43 million was available for treatment services and programs. However, we placed $12.7 million in a pool to fund treatment services for people without insurance. So what this was a new client-centered funding approach to ensure that treatment dollars follow the client and are not encumbered to any one particular agency. So this is a change in funding that we did. What we used to do is we used to say, okay, we used to give, let's say, $5 million to one agency for treatment, and that would stay on the books. So even though they didn't use that money for treatment, then they would want to use the funding for other services. So the thought here is that we were saying that if we have it in a pooled funding, so just like an insurance company, they would bill us for the services that were provided. And then towards the end of the year, we will look to see if there's any money left over that we could reallocate to other things, other priorities going forward. So this is the first year that we're doing that. It's a pilot program that we're working on. And then also, that the funding cuts really put a strain on the workforce and providers in Cuyahoga County to serve more people with less resources. So the hardest hit programs of 18 that had the greatest impact on their clients are the following. So the Adams Board of Cuyahoga County Residential Assistance Program was cut by $1 million, from $3.5 million to $2.5 million. Mental health and addiction crisis services for adults and children were cut by over $1 million, from $8.2 to $7.2 million. Medication-assisted treatment or outpatient treatment for individuals living with addiction was cut $2.3 million, from $9.8 to $7.5. And then SoberRecovery Housing for individuals living with addictions was cut from $405,000 from $1.3 million down to $956,000. So let me tell you a little bit about each one of these. So the residential assistance program that we cut by $1 million. So our RAP program provides $1,100 per month per client for rent and $200 in spending money for clients while they wait for Social Security, supplemental security income, disability benefits, and acceptance into the state residential state supplement program, which is RSS. So we know that housing is a basic need for recovery, and without a place to call home, that some of our clients end up living on the streets, in shelters, or moving in and out of homes of friends and families. No new clients with mental illness were able to utilize this program to obtain housing in our adult care facilities because of the cuts. We had to close the program at the $2.5 million to maintain the folks that we have on there now. So as a result, we did a major review of the program to confirm eligibility of clients. We want to make sure that everybody on there, if they were receiving RSS, that they were no longer receiving our subsidy. So as a result, 100 clients were removed from the program because they were receiving other benefits. So currently, there's 189 eligible clients receiving RAP. And this number is variable based on providing benefit awards and approval. Now, the RSS program, that opens and closes as it goes along when people get on that. But the hope is that they will get on the state supplement so that the Adams Board will no longer have to provide for that. So also to ensure that the Adams Board dollars are spent responsibly and all of our clients reside in facilities with a high level of care, because a lot of times we would receive complaints from clients living in grievances in our client rights department of the condition of the homes. So what we did this year was we developed a peer seal of quality program, and that is where we contracted with LifeWorks, which is a peer agency, and they would actually go out and do an inspection separate from the state, that they would make sure that how the living conditions are. Are they clean? Is everything adequate? Is their food supply well? Are medications locked up? So we wanted to make sure that we were contracting with the best homes possible. So that was a new program that we started. And then also throughout the year, on Tuesdays and Thursdays, that peer program will be going out and visiting the residents of those adult care facilities to make sure that everything is going well, as well as a mean of communication between us, the clients, and the operators of the homes. So when we talk about crisis services, which was cut by over $1 million, so the ADAM boards fund the following crisis services in Cuyahoga County. The first is our 24-hour crisis hotline, 623-6888, which is operated by Frontline Services. And then they also operate a mobile crisis unit operated by Frontline, and they also operate for us the crisis stabilization unit, which has 15 beds in there. And right now we have 2 beds reserved for the Cleveland Division of Police as diversion beds. So which brings me to the point that you may have also heard about a countywide diversion center. So we've been engaged in conversations with the county executive, the courts, the police departments, and other stakeholders. However, no decisions have been made at this time going forward with that. But what we did is we received a SAMHSA grant to take those 2 beds offline, available for districts 1, 2, and I believe 4 also, that police officers, if they come across somebody with mental illness, or if it was a crime but it really didn't warrant an arrest, they could take people to the diversion center where they would be able to be stabilized and receive some treatment and then referrals to services.
Yes, Councilman Brown.
Thank you, Madam Chair. So with the diversion program, you said which districts can utilize those?
Districts 1, 2, and I believe 4. District 4. Because there's only the 2 beds available and it's a pilot program.
And when did it begin?
This started when we got the grant, we started in January, right?
And we had to have a little time to ramp.
You'll have to come forward if you're
Yeah.
going to speak.
It's
Thank
okay.
you.
It's okay, Maggie. Yeah,
Okay.
we got the grant last year, so there was time to ramp up the services and work with Frontline Services to see how the program was going to work. But so I believe they started accepting people in January.
So we have utilized this service. Can you probably don't have this information available, but can you let us know how many people have gone through
Yes.
the service and if the officers were instructed on utilizing this resource, I would imagine?
Yes, we worked with the police department, Captain Purcell, and there were a brochure or a policy developed that would say how you would access this, when you would be able to take somebody there. So we could share that as well.
So is this primarily like a pre-booking kind of type service? Would you classify it as that, or?
Yes, it's before arrest. So it's
Okay.
just that if a person is exhibiting mental illness, and let's say they did a minor crime, or even if they didn't, if somebody they saw somebody walking down the street that was obviously suffering with mental illness, that they would be able to take them there.
Okay, and the last question is, if I understand the rules correctly, those individuals can only be kept in that particular unit for 48 hours, is that correct?
Well, actually, it's a voluntary.
Okay,
So they would be able to stay, we say 3 days that people could stay, 36 hours, but yet some people could stay longer if they want to. But it's
so
not a locked
72 or
facility.
36, what's is it 3 days or?
3 days, right?
It's up to 72 hours.
Yeah, up to
Okay.
72.
And peer support.
Yes, and part of it is that there is a peer supporter there. Thank you, Maggie. There's a peer supporter that's available there. So when a person comes in, then that peer person, so a peer is somebody who is living with mental illness or addiction, but they're living in recovery, that they would be able to talk to that client in order to encourage them to get into services.
Okay, and just so we're clear, the information that I would like to receive is the number of individuals that have been, that have utilized this service,
Yes.
if you will, and which districts have utilized, they were in. Thank you.
Yes, we will get that for you.
Can we, while we're on this point, describe to us why districts 1, 2, and 4 were selected?
Because there's only 2 beds available, and District 1 and 2 are close to the facility. It's on West 85th in Detroit. And then District 4 was added because it was a nearby facility, and just probably based on the usage of 1 and 2 that they would be able to add.
So you're talking about county districts, correct?
Oh, police districts.
police
Oh, I'm sorry.
districts.
It's,
Okay.
I'm sorry. No, I'm sorry. I'm sorry. I didn't
I was
clarify
like,
that. Right.
Westlake, I'm about to get on
Oh,
you.
no. I'm sorry. Police
We
districts.
thought they were county districts. I
No,
didn't
I'm
catch
sorry.
that.
Police districts.
Yeah.
I recognize that. That's what I'm saying.
So it all makes sense now.
Now it makes
Those
sense.
are
Okay.
the two.
We think county.
You okay, Pernell?
I'm feeling
Cleveland
better.
Police
But I do have a
District.
question,
Either because it just
Madam Chair.
doesn't, come up that often.
Comment that often. Yes, I'm sorry.
Police districts.
Police
Police
districts.
districts, okay. Madam Chair, may I ask a question?
Yes, go right ahead.
In that same vein, there's a question I've been working on, and Councilwoman Brown as well. In terms of potential mental health facilities and the number of beds, can you speak to, are you aware of if there's any state regulation or any regulation at all that says how many beds a community can have?
There, as far as a community, no, but by each
city or
facility, that's there. It's the IMD rule, Institution of Mental Disease rule, that you can't go above 16 beds. Then it could be covered by Medicaid, but you could have 100 beds if you want, but you could accept private insurance or you could accept self-pay
16 beds per facility.
per facility.
Okay.
So like the facility out at Parmadale, we have recovery support beds there and recovery treatment beds, but they're paid by us. They're not paid through Medicaid. So they have more than 16 beds.
Okay, thank you.
Question, Councilman?
Director, how long is the grant for that funded the diversion beds?
Oh, it's just a pilot program, so it's only been for a few months, or 6 or 7 months that we received it.
So
grant.
how long will the grant continue?
It's a 3-year grant. It's $300,000 per year for 3 years for a pilot program.
Okay.
Continue, please.
Okay. And then also we have crisis stabilization beds for youth, which are operated by Applewood and Belfair JCB. And then Frontline also operates the then we also have the St. Vincent Charity Medical Center Psych Emergency Department, which is on East 22nd Street. So when we talk about the crisis services, the $1 million cuts also comes in the midst of our opiate crisis and a time that suicide rates are really escalating in Cuyahoga County. The suicide rate has increased 14% between 1999 and 2017. In 2016, 174 people died by suicide. In 2017, 176 people died by suicide. And in 2018, Cuyahoga County saw the highest number of deaths and suicides since 1985, with 203 deaths. So the Adult and Children's Mobile Crisis Team saw an average of 7 to 8 individuals per week, or about 400 people within the past year. However, they're not always able to respond on site immediately to provide an assessment, and some clients may have to wait up to 24 hours to have an assessment because there's just not enough staff for that. A vast majority of individuals who receive crisis services have no insurance. In 2017, 85% of adults and 50% of children and adolescents received a crisis intervention service had no insurance. Working in crisis services is very hard on staff, clinically challenging, and often requires going into unpleasant and sometimes dangerous environments, especially throughout the overnight and the weekend hours. The mobile crisis workers are assessing people they do not know. Many do not know. Many of the people there don't want help or an assessment, and many are out in the community and often in someone's home. So due to the funding cuts in calendar year 18 and inadequate funding to meet the needs of our community, Frontline's unable to attract and retain experienced staff. Just want to talk a little bit about justice-related services. So the Adams Board has a long-standing relationship with the county and municipal drug recovery and mental health courts. The Adams Board has always had a jail liaison program to help the mental health and developmental disability courts get people out of jail as soon as they could into treatment. So just recently, the administration, we took a closer look at the jail liaison program, and we decided to revamp it to go ahead and improve assistance in getting people connected to treatment faster. So in the fall of 2018, we issued a request for proposal for services. We created, in partnership with the courts, a new and jointly funded mental health jail liaison specialist position that's actually housed at the court. And the purpose of this position is to increase communication between the courts, the Adams Board, the jail liaisons, as well as our providers. The dedication to revising our work through this program led to strengthened relationships in the county jail over the past few months. Actually, they reached out to us recently on the death of a veteran, the recent suicide that they had. The jail staff, they reached a few other agencies, and they weren't able to assist. They said they would be able to drop literature off, and maybe that would be sometime within the week. So they called us at the Adams Board. And what we did is we immediately called Frontline Services, and within 4 hours, a team was out there, Frontline Services, to help the inmates as well as the workers there kind of deal with what they saw there and how it was. And many of them did express that they needed to have additional service. So I just give that example that this is a step in the right direction regarding the county jail.
Madam Chair.
Yes, Councilman.
Scott, are you aware of what number of individuals in the county jail actually have mental health?
I don't have that number offhand, but we can get that for you. But there are a lot.
Okay.
There are a lot. And we recently took a tour of the jail. The board members, executive staff, we went out and took a tour of it, and we saw the mental health pod. And we agree there needs to be a lot of changes made for that, and making sure that people do get the treatment that they need, or if they don't belong in the jail for whatever reason, that they get into treatment as well.
I would like to hear those numbers from you, but I'll just share what some advocates have said.
Okay.
Out of 2,100 individuals in the facility now, about a third, they say 700 had mental health issues. So that actually connects to my original question. If we had a mental health facility that could potentially serve a population of 700, how does that jive with a facility that can only take 16 beds? What does that look like? What does it look like with a mental health facility that could work in partnership, to provide a need that's served? One of my colleagues just mentioned pre-booking a police officer making an arrest, but instead of going to the county jail, go to a mental health facility.
Right. And those are discussions with the diversion center that are going on with various stakeholders. And it wouldn't be like for an entire 700. It would be for people with nonviolent offenses, people to be able to get in treatment, and they may not reside in that facility as well. There could be outpatient treatment related to that as well. But it was the fact of, getting the most people that we can out of jail to get the treatment that they need, because the jail is not the right setting for treatment.
Okay.
Okay. Is Josh here, Beth?
Yes, he is.
All right. So right now I want to introduce Josh Rumenski, and he's going to speak to us about the necessary.
Start, Scott.
It's just a statement. I'm sorry.
Oh, I'm sorry,
It really just following up. It's we know this, but we've spent a lot of time, as everybody knows, focused on the jails in recent months,
Yes.
to say the least, and trying to determine what we can do to change things, make things happen, hire CEOs, on and on. And we know, of course, that there are these mental health issues that are very big and in a way that perhaps more than they ever have been before. The drug addiction issues are big. And when you mentioned what struck me is when you mentioned the high rate of suicides in the county, that is indistinguishable from the higher rates of suicide in the jail, as far as I'm concerned. I imagine that it's pretty much the same reason, so just saying the obvious, that one of the things I think it's important about this conversation is not just the needs the Adams Board has, and which it deserves and has built a reputation of respect in the community in that way, but that this really is very important in terms of our conversation about the jails as well.
Yes.
This is a big part of it that's not overlooked, but not focused on nearly as much. So,
Okay. Yes, thank you, sir. So Josh Rumenski, he was our keynote speaker at our annual meeting, and Councilwoman Conwell was there, and she said, you know what, I think that the council would like to hear from him as well. So he wants to share a little bit of his story about how important crisis services are. Josh?
Welcome.
Thanks, I appreciate that.
Just state your name and share with whatever you would like to share.
Yep. So I am Josh Rumenski. I am a suicide attempt survivor, and also I like to try to advocate as much as I can. I'm actually a part of District 2. Actually never met my councilperson, so it's good to meet you finally. So I think it's also important to recognize that we don't talk about mental illness and mental health and suicide prevention as much. Being someone that has lived with mental illness all my life, as well as survived from 2 suicide attempts, it's important to advocate for those crisis services. I remember my second attempt in particular. My dad took me and my mom took me to Fairview Hospital, which is over on the west side in West Park, and we were in a bed and we were talking to the doctors about what was happening, and they said, you know what, hey, we don't have any beds available, so why don't you just take Josh home? My mom was quite stubborn, and thankfully she was, because I wouldn't be here today if it wasn't for her. She said, no, if you take him home, I won't see my child again. And it's because suicide is such a hard ideation, and those thoughts that you have are very overwhelming. I mean, we all know 911. That is the number we call when we need help, primarily for medical or for police services. But how many of you know the Adams Board number offhand, or the suicide prevention number, the national one? How many of us on the council, how many of you know it offhand?
211. Is that, were you asking for the,
Yes, do you know both of them offhand?
not both?
And I personally, I think that's a problem. And I think that it's not our fault in particular, but I think it's education aspect and running these campaigns. I had a crisis moment when I was in school. I was telling we had to write a vignette about our story and stuff, and my teacher told me, I was telling her about my story, and she put her head down, and then she expressed some things about my views, and she said that I was terrible and disgusting for my views. And for me, as I think it was 16 or 17 at the time, that is hard to take, because this is supposed to be a mentor and a teacher that's supposed to be helping me. Unfortunately, I wasn't. I had the nurse there that I had a close bond with to help me calm down from that crisis. But students aren't always able to have those different connections. So if we are able to help have these different programs where people are able to come to a bed and kind of have this area to sit down and relax and be able to talk to someone, or have these services, and I guess like therapies there that can help us calm our thoughts and be able to recognize what we're doing, or what different thoughts are going on. I mean, we see suicide as an ambivalency. People don't want to die. They just want the pain to go away. They don't want this pain overwhelming them, right? I mean, none of us want stress in our lives. I mean, we all have that. We all have our pains and our struggles, but it really is prevalent with mental illness and drug addiction, because these things are so overwhelming in our community. Yeah.
Can you share what you do today?
So today, after my second attempt, I started a business called Happy Thoughts Candle Company. And my Happy Thoughts Candle Company obviously is Drive for Me Thriving. And I put the suicide prevention number on the back of each can, and then I give 20% of the proceeds from every one of my candles to different suicide prevention charities, like the AFSP, the American Foundation for Suicide Prevention, the Ohio chapter, as well as different NAMI, the Greater Cleveland, Jog County, Lorraine County. And I help do different speaking events that they may need, because I want to share my story, but it's not only about sharing my story, it's about giving the power to others to share their story. So having those peer-to-peer, trying to gather my thoughts. Having those peer-to-peer helps recovery, and getting those kind of groups together. I was at one in Geauga County. It was a NAMI event, and it was It was just a group of us just talking about different struggles. And it was just an uplifting moment because we were able to say, you know what, hey, I too struggle with that, but we're not alone. And so if you're with crisis services, if we're able to get people to those beds, but then also get people into those groups and help facilitate those groups to help people kind of realize that you're not alone in your fight. It can help change lives. So thank you.
Any questions for Josh? Councilwoman?
Thank you, Madam Chair. I just want to applaud you for coming forward, sharing your story. I did have an opportunity to hear you speak at the event, and I also was lucky enough to get one of your candles, which absolutely smell wonderful. I use it
thank you.
regularly. So I would encourage anyone in the audience to support this young man because one of the things that I took away from your speech is also language, the could versus should,
Yep.
and how important that was. So I'm more conscious of how I speak to younger people and how much our words matter. So I just want to thank you for the work that you're doing and to encourage you to keep on doing it because it's making a difference.
Thank you. I appreciate that. It's super important to also, like you said, talk about the language and educate, especially educators about it because, I mean, I don't want to, because that guilt can really harm mental illness in particular.
Any others? All right. I want to thank you for coming out and thank you for presenting.
Thank you.
And hopefully this is live stream, so hopefully it will reach someone that is of your age or thinking about suicide and it will help them.
Thank you.
Thank you.
Thanks a lot, Josh.
Thank you.
Thanks for coming, Josh. Also, when I got back to the seat, the executive staff said, you said that we serve 100,000 people. That was a misstatement. It's 10,000 people. So they were all excited. Okay. So then when we want to talk about our addiction continuum of care. So funding cuts totaled $3 million for our SoberRecovery Housing and medication-assisted treatment. And both of those are important to the continuum of care for people recovering from substance abuse disorders because it provides them with alcohol and drug-free living environments and supports for sustained recovery. So at this time, I'd like to show you just a real brief video, but it's really good. It is explaining what MAT, or medication addiction treatment is. That was playing before over me?
That wasn't very
Kind
good.
of.
Millions of people in the United States are struggling with dependence on opioids.
Don't go too far.
And this problem continues to grow. Opioid use disorder is often viewed as a moral failing. In reality, it's actually a chronic disease like diabetes or asthma. And like other chronic diseases, opioid use disorders can be treated. The most effective therapy is medication-assisted treatment, or MAT, which combines drugs with behavioral therapy. So how does MAT work?
Opioids alter the chemistry of the brain by attaching to opioid receptors. When these drugs attach to their receptors, they reduce the perception of pain.
That's Dr. Peggy Compton, who's done research on opioid use for NIH.
And a person with opioid use disorder is physically dependent on these drugs and needs higher and higher doses over time, which can lead to overdose or even death. Fortunately, there are FDA-approved drugs that can help. They curb cravings and block the effects of opioids. People are then better able to manage their disease, which can help prevent relapse.
According to the U.S. Surgeon General, medication-assisted treatments have been shown to facilitate recovery from substance use disorders and prevent relapse. MAT is crucial to long-term recovery and helps people live healthier, more productive lives.
We just like to use this video to show people, right, exactly what it is. And once again, it reinforces the idea that addiction is a disease.
It's important to stress the difference between dependence and addiction. Dependence is a tolerance one develops over time, and the withdrawal one suffers.
You brought your little friend.
Addiction is a behavioral disorder.
You brought your friend. Can I ask a question, Scott?
Certainly.
Can a person get over opioid use without drugs?
Yes, they can do that. It's the abstinence model, the 12-step program model. But as we're going forward with the treatments and how we're in this this epidemic, is that they're finding that the best way to do it is the medication-assisted treatment.
Is it the quicker way or the better way?
That's a good two points on that, right? Dr. Leslie, what do you think? If I could go.
I would say that it's certainly the better way. I don't think at all that it's the quicker way. I've worked using Suboxone. I've given Vivitrol to the inmates at county jail when they're leaving. I certainly don't, it's not the only way, because certainly some people can become sober without using it, but it's very difficult. On the other hand, because we look at it as the medical model, you wouldn't say to a diabetic, don't use medication, just stop your carbohydrates, your sugars, things like that. So it's a help. We need to give people something that will help them, because as you saw in the video, that's physiologic cravings. It's scientific, it's in their brain. And what these medications do, when you saw the receptor that the opioid sits in, these medications block that receptor, so the opiate can't get into it. So if you understand the scientific model of it and you think of it as a disease, as an illness, you'll see that it needs to have the same attention that we give any other medical illness. And I'm a psychiatrist, for many years working in this area.
Can you state your name for the record?
Yes, Leslie Koblenz, and I was the only psychiatrist at county jail for many years.
Thank you.
So it's...
Councilman.
While you're up, isn't it?
I know that these issues around using methadone with heroin addicts and other issues have been around for decades that I'm aware of. Isn't it true that if we didn't have the ability to use these alternative drugs, that we would lose a lot of people if we were to take an approach that might be more attractive to somebody who's not addicted to drugs, but would be my assumption we would lose a lot of people along the way.
I think we certainly would. And many people do very well going to AA and NA and HA and all the different organizations, but there's many people who need something different. And it's looking at harm reduction versus abstinence. If you take the abstinence model, you don't want to give any opioid medication to help a patient. If you take the harm reduction method, you see how it can help to give something that is medically required through a prescription to help a patient as they're going through their detox and treatment.
Yeah.
Thank you.
Madam Chair,
Okay,
before you leave,
Dr. Leslie?
I can patiently wait on Scott to get us, hard numbers on the jail mental health population. But since you were there, do you have anecdotally a sense of what the mental health numbers were there?
So there's two areas we look at. There's serious mental illness, such as your schizophrenia and your bipolar. And then there's other areas of mental illness that still needed to be seen by a provider, such as a lot of depression, anxiety. And as I say, I was the only psychiatrist there, so how can one person take care of the whole place? I was there for years, along with a nurse practitioner. We really need to get more people in there. I got a lot of ideas I'll give you if you're interested.
Did you experience suicides over the time you were there?
Yes, but I left April 2018. I'm a lawyer in a former life, and I knew I needed to do what was right for me. I left April 2018, and a lot of deaths occurred after I left. I'm not saying it was my leaving, but I can give you some great ideas how to help things in the future.
Okay. All right, thank you.
Continue.
Okay.
Yeah, definitely.
So MAT was cut by 2.3 million. And it, like Dr. Leslie was just describing, you know, it allows an individual to regain a normal state of mind, free of induced highs and lows, and can reduce symptoms of withdrawal and craving. So it is a best practice in treating opioid disorders, and clients receiving MAT are actually 3 times more likely to complete treatment and remain in recovery. So it's an important thing. The next thing we want to talk about is the sober and recovery housing. So this says, you know, that we cut it by $405,000. So actually there are 4 levels of sober recovery housing in Ohio, and all are based on the level of care that someone needs on their journey to recovery, and they vary in structure and operation. Sober recovery housing provides an alcohol and drug-free living environment for individuals attempting to abstain from alcohol and drugs with no formal treatment services, but either mandates or strongly encourages attendance at 12-step health groups, compliance with house rules, participating in house chores, and attending house meetings. So residents can stay in the house provided that they comply with all of the house rules for as long as they would need. But this also helps them practice, strengthen recovery skills so they do not relapse. So when a person goes, you know, they go through detox, then they go to residential treatment services. Oftentimes, and most of the time, it's not good for them to go back into the environment that they came from. Their dealers are there, maybe other people are using there. So we really need to have the opportunity to have the people live in a sober environment, that they could participate in MAT during that, outpatient treatment during that, and they have a safe place to live with that. Because if not, then relapse is more possible, and it continues the cycle all over again. So we hope, okay. So when
Can
we get
I
to,
ask a question in regards to that? So
Yes,
what,
ma'am.
you said it was cut from 1.3 to 9. So what has occurred since those cuts?
The cuts. So once has occurred in it that we are trying to maintain people in there. We're trying, right now, we feel that it should be about a 3-month time frame that a person should be able to, but they could stay later. So right now, there are people who want to get into recovery support, sober living environments, but there aren't enough of them. So that's why we'll be requesting additional money to expand the available beds.
So right now, you're trying to maintain the length of the stay per person.
Yes.
So the cuts kind of produce them from going to a 3-month to what type of stay? A 1 month or?
Right now, we're averaging the 3 months is what we're really trying to do. But then there are people who would need to have
Longer?
that as well, or longer. So it's all kind of individual.
Okay, thank you.
Yes. So then now we want to get into our requests, right, of what we would like to request for. So it's a total of $7.8 million in additional funding that we're requesting for 20 and 21. And we also would like to consider that part of the board's base allocation for Health and Human Services going forward. So the request would assist the board in funding 4 of our main priorities: the high-quality housing, crisis services, medication-assisted treatment, and sober housing. So with the residential assistant increase, with the additional money, we would be able to apply $1 million of it to restore the original cut that we had. And then we would use the other $2.1 million to reopen our RAP program and serve approximately 200 more clients living with mental illness while they're waiting to get on other services. The crisis service increase, the $2 million, we would be able to restore the $1 million cut that was previously made, and we'd be able to use the other $1 million to increase services so that 1,000 more individuals can receive assessment in person via the phone or text or chat. And that would reduce the wait times for assessments as well. And then it would also, a main thing that we want to do is support the workforce at frontline services by ensuring adequate staffing levels and competitive salaries and employees. Because like we said before, it's a very stressful job. It's hard to keep people in those jobs. So at least if they had adequate staffing levels, that they would be able to maintain a high quality level of service. They do have a high quality level of service now, but there's just not enough people to do that. And one of our board priorities also is workforce development. And we also feel that this would help with that as well.
What are the wait times?
The wait time now is about 24 hours for a person to receive an assessment, but it could go longer. And also with the mobile crisis team, if there were additional staff, we had additional funding for that, they would be able to have additional teams that would be able to actually go out on scene and respond to crisis.
Okay, thank you.
Okay. Our next one is the medication-assisted treatment. And so this final 2.7 million will be allocated to provide more clients access to MAT and sober recovery housing. We kind of lump these two together. So by allocating 1.7 million for MAT, the Adams Board will be able to restore a portion of the cut, as well as increase the availability of MAT. We're estimating to about 566 more individuals. And this will ensure better outcomes for opioid use disorder, help individuals sustain their recovery, and also help prevent relapse. So also with our sober recovery housing, right? So allocating $1 million to it would allow to restore that $406,000 cut. And we would be able to provide sober and recovery housing options to an additional 547 individuals, assuming that that average length of stay is 3 months. That's what we base that on. And then that will also be able to ensure better outcomes for individuals, help them maintain long-term recovery, and then help prevent the relapse. So once again, I want to say thank you for this consideration and to consider this, and we are happy to answer any questions that you have. And Reverend Golston wanted me to tell you that the crisis number again is 623-6888, and that's 24 hours a day, 7 days a week, and that's for people with mental illness and also AOD issues as well, alcohol and other drug issues as well.
All right, I'd like to open it up for, I know we've been asking questions. Councilman.
Of the 1.7 million requested for Medicaid-assisted treatment, how much of that is for medications themselves, and how much is it for
the
personnel costs involved in running the programs?
I don't know the exact number of what that would be. We were basing the 1.7 million on, let's say a Vivitrol shot is actually $1,000 per shot. So we were basing it on that, as well as Dr. Leslie, Maggie, Alicia, I'm sorry.
Methadone and Suboxone costs.
Yeah, the cost. So we were basically on the cost of the drug, right? Were we building in any for personnel costs? I don't think we were. No, that was just the regular cost of doing business with the agency. But the cost is really with the medications.
There ought to be a way to negotiate lower prices. I can't imagine these medications cost $1,000 a shot.
Mm-hmm. They do, right, Dr. Leslie? Oh,
Yeah. Well,
come up forward, Leslie.
yeah, I believe you,
Oh,
but I'm saying we ought to be able to produce them for less money than that.
Right.
There's got to be a very high markup on that.
Right, we agree with that, and I know that the state, through their central pharmacy, that they are working on trying to get lower prices for medications. We know what they do with that for psychotropic drugs now.
Councilman?
Scott, I want to step back for a minute, partly on, most of us have been here for the 8.5 years and through the budget cycles since 2011, which was the first one the council had. Help me if I'm not remembering this as well as I think I am. If you can, 2011, our first biennial budget was in the fall of 2011 for 12 and 13, correct?
Correct.
And that's when we first went to a biennial budget with the county. It had previously been on annual budgets. We had the budget proposal from the previous executive in 2011 set aside, I forget the exact number for the Adams Board. I know, though, as a previous chairman of Health and Human Services, that we were able to convince the executive at that time to increase the amount for the Adams Board that particular year.
Yes.
It's my memory that in 13, the administration again proposed an amount for the Adams Board, and I believe that again the council was able to negotiate with the executive for a higher amount. And so that brings us to where we apparently ended up, right?
Yes.
At 39 million.
Yes, sir.
And so we've been, as you said in your statement, flat since that time.
Yes.
And so you started off your presentation by thanking, well, actually, it's the executive, isn't it, who promised you that they wouldn't reduce your budget. You didn't really need that promise for us because we would have never done that in the first place.
Yes, sir.
So it seems to me the council initiated a health human service levy increase in 2013 early because we were able to determine through a lot of the work, particularly that Councilman Miller did as Finance Committee chairman at that time, that we were going to be in trouble quickly.
Yes.
And so we were able to successfully do that. That particular levy, which is the smaller one, is the one that's up again in March of this year.
Okay.
And if we go for an 8-year, which we would like to, well, let's say this is an important opportunity, not without challenges, that's for sure. But the only way I could see, and this is not a definitive statement, it's just a point of view, the only way I could see us getting all the way to where you need to be, which you're proposing, is if there is an increase in the health and human service levy that's successful. And in the short run, that doesn't even really, take care of all your issues. But in my mind, can there be an increase in your budget after it being flat for several years now? I would say yes, in spite of the difficulties and challenges we have right now. Beyond that, in terms of what you need, I think there would have to be an increase in the health and human service levy in March in order for us to be able to achieve that goal. Okay. Now, that's just a short of it. I just want to get that off my chest because that's what we're kind of here to talk about, and I just want to speak
Definitely.
directly.
Yes, thank you.
Madam Chair.
Councilwoman Brown, then Miller.
Thank you, Madam Chair. So just to follow up, I'm really interested in going back to the grant that we initially talked about. Can you share with the committee how much the grant was for relative to the
diversion?
Yeah.
With the SAMHSA? Yes, it was $330,000 per year for 3 years.
And
Right, Trish? Yeah.
do we know how that was determined and if there are any administrative costs? Is it on a per day, per bed, per person?
Yes, when they put the cost together, all of that was included in there. Administration, as well as paying for the peer support workers to be there. And the grant was put up by SAMHSA, and we followed all of the rules with doing that. But the $333,000, that was basically what the grant was for, right? I mean, so we got up to the maximum amount of that with what we described the program as.
Okay.
Yes.
So what metrics or what will be used to determine a success and if the model is sustained in the event that this is a sustainable model?
Yes. Maggie, would you like to come on up? Maggie oversees this program.
Good afternoon, Maggie Tolbert. So this grant, we're following what SAMHSA has asked for. They want to make sure that people who do not need to be in the legal system is not. So it's divert away from the legal system. So there's a percentage, and I'll be more than happy afterwards to give you a summary of the grant. But what we're looking for is that what percent of the clients are the consumers that the Cleveland Police pick up that they feel does not need to go down to the jail, should not be in their system, but need treatment. We have peer supporters that are on site at Frontline, it's the Crisis Stabilization Unit, that would then link them to service or relink them to service. We'll stay with them for a period of time to make sure that they're getting treatment and that their primary agency are going to see them. At that point, then they will step back. At any time that client then get into another crisis, they're willing to also step back in to help with that. So is SAMHSA, the federal government, is looking to see if you have designated staff that is paying particular attention to certain areas, will that make a difference?
So were the officers giving any additional training, or is this that they're at their discretion?
No. Well, it is at their discretion in terms of who they pick up. But in terms of starting the program, we're working with Captain Purcell, who's one of the major people who helps out with CIT. So these officers have
CIT?
Crisis intervention team,
Okay, thank you.
and that's countywide.
right? The Adams Board provides the CIT trainings.
Okay.
So they visit these districts, because initially we started with first district and the second district, and now it's going to the fourth district. They visit them at their, I'm sorry, is it called parole, where the officers meet? The roll call.
In the morning.
Okay.
To explain the program. They have a write-up in the brochures, as well as the Cleveland Police themselves under Captain Purcell. He also is communicating with them. We have monthly meetings at the board also to go over and see how the problems, what the barriers are, and those type of things. We have reporting requirements that we have to send to the federal government, SAMHSA.
Share those, right?
Yeah, we can share all of that.
That would be great. I think it should be obvious that this is a particular interest of me as it relates to criminal justice reform and the overcrowding at the jail. So I think it's all interrelated. So I'm very excited about the program, and I hope that it does yield some positive results to help us reduce that population and also provide the services for for that population that's being put into the jail wrongly. So I am grateful for the work that's being done and you being able to secure that grant. And so just interested in learning if it's something that we can replicate on a broader scale and make it more sustainable. So those results will be critical for this council.
We were happy to get.
All right, thank you very much. Oh, I do have one other question. With the pricing, unrelated to the jail, with the pricing, do we get the 403B pricing for the drugs that we utilize?
Felicia, we could check into that.
Okay.
And for the SAMHSA grant, does that include just mental health or drug addiction?
It's focused on mental illness.
Just mental health. Okay. Councilman Miller?
Madam Chair, Director, I would just like to second what the council president said a few minutes ago. The Health and Human Services levy is currently running at an excess of expenditures over revenue of $20 million per year, and that gap is increasing by about $5 million per year because of the fact that the revenue is fixed. It's controlled by House Bill 920, and it just essentially does not change from year to year. And meanwhile, the costs of everything go up every year. So I would just say that it's extremely difficult to pay for what we're doing now, let alone any increases, without there being an increase in the Health and Human Services levy. The fundamental problem that Cuyahoga County faces right now is that all the numbers are going in the wrong direction. If you look at the number of opiate deaths, the suicide rate, which you pointed out, the numbers of people incarcerated, the number of children in county custody, all these numbers keep going up, and if we're going to have any chance of turning this around, we're going to have to fund services and do it with a strong prevention and long-term focus, and so for these reasons, I totally understand the need for these services and believe that we need to work very hard to try to find the ways and means to make it possible. Thank you.
Thank you.
Thank you. And again, in the same vein as our council president with the mental health levy and just what we go before the community to ask for, I come back to my original question to you about the 16 bids for Medicaid. And just throwing this out there, that is in the context of if Medicaid pays for the operating costs of the facility, it's 16 bid. But if Medicaid is not paying for the operating costs,
It's
that's
not
not
the
a-
operating cost, it's the cost of the treatment that it would cover. It's not the cost of operating it. But if you could have a 50-bed facility, but Medicaid won't pay for those services. At first, this is a federal rule, and at first, the old administration at the State Department was saying that really doesn't apply to AOD issues. But it hasn't been challenged, but yet the same time, we really can't go over the 16 beds and be covered by Medicaid because the federal law has a different interpretation. So originally, we were hopeful that we were able to go over the 16 beds with the State Department's interpretation. But with the new administration and another interpretation, that's not so. So, so we are fighting with that. The Board Association and other providers as well are fighting with that. But if not, then we would pick up the cost of those services.
Okay, thank you.
Any other questions? All right.
Yeah, I would like
Thank
to
you very
thank you
much.
all very much again for listening. And we'll be glad to answer any questions again, if you think of it afterwards, and then we'll also get back to you with those other questions that you had. Okay, thank you.
All right. Can you read the next item into the record, please?
Discussion item 7A, Propel Cuyahoga Workforce Services Program.
All right, and who will be presenting today? So just to my colleagues, I had prepared for you, you have a copy on your desk, this Propel contract, when it originally started, what was the cost, and the breakdowns for the amendments, and currently what this RFP will cost us. And I think I stated at the last meeting, I think everybody was here, when we originally passed the legislation out of the committee, was I had some concerns about, at the time, the different providers, the different RFP that we were doing. I don't think we were fully explained about that, the doubling in cost, and the reason of using different providers. I felt that we, as a council, had worked on diversity and making sure the contracts were able to be open and utilized by all organizations that wanted to participate in the bidding process with the county. And I felt in this that kind of went another way. So fast forward, I have met with all concerned about my concerns about this contract. The other ones have been answered, but I still have something in regards to the doubling of the price of the contract in itself. So I wanted to bring that forth for discussion. It is still the way it is. It is passed out of committee. It is supposed to be on the next council meeting, but I wanted to bring my concerns and have it explained a little bit more to you guys about the doubling of the cost. So that's where we are. It is still on council agenda. I don't know if we're going to make any amendments or anything like that, so I hope that you guys will ask questions. Take it away, Kevin.
Kevin Gowan, JFS Administrator. I don't have a lengthy statement. This was I'm here largely to answer questions, but to address the direct concern that Councilwoman Conwell first brought up regarding the increasing cost of the contract. We are essentially attempting a new model at providing these services. These are for our clients at JFS who are in the most need of services. This is largely our cash population, our TANF population. We're doing this and we're changing the model in the hopes that we're going to drive better outcomes. And I'm not referring to compliance, I'm referring to getting people to better outcomes and getting them onto career paths into better employment opportunities. It does require us to invest more money. And we are recognize that, and we recognize our responsibility as an agency to monitor this. We have very specific performance requirements and incentives built into the contract that we'll be monitoring and closely paying attention to how that is moving forward, and if it is in fact delivering better outcomes for our population. And so, having said that, I'm happy to entertain questions.
Okay, in my meeting with you and the group, Dave Merriman kind of pointed out in the original RFP there were three main objectives in the original RFP, and then the new RFP there were five objectives to, I guess, to show me that we're actually expanding on our objectives that we're requiring from the individuals that are providing the services. And in looking over them, really 2 and 3 of the new RFP kind of went with the objective in the original RFP. I mean, it was just stated a different way to my knowledge. So instead of having 5, 1, 2, 3, 4, 5, you would still end up in 3 to me in terms of the objectives. So really in investigating this a little more, the objectives changed slightly, but not too much. And not just the doubling of the amount that was the concern of the contract, because I know things go up. I mean, that's what we were talking about earlier today. It was also that the number of the participants in the work study have not increased. So if you could touch on that a little bit. So we're paying double the money for the same amount of work study.
So the objectives are in a simple way to aside from the compliance piece. Compliance piece is wet work participation, make sure that people meet those rates so that the program doesn't suffer and suffer any penalties from the federal or the state program. But the objectives that I'm really talking about when it comes to outcomes are placement and retention. Okay. We also have in there incentives around our population receiving jobs that are above the minimum wage. And we put incentives around that as well. So not just jobs, but better jobs, working towards a living wage. In terms of, it's really the model that has changed in that where we had separate entities providing these services, we are centralizing this so that we have the provider providing the services from start to finish. So the same provider that's responsible for that compliance piece of work participation is responsible for getting them into better outcomes and getting them into career paths and better jobs. And shepherding them through, pardon me if the sports reference, playing quarterback for them and getting them through the entire program so that they're meeting their work participation rates, and not just doing that, but getting into career paths in industries that have a presence here in Cuyahoga County. So that's the intent there, is that that they have the incentive, meaning the providers have the incentive to get them through that entire process, so we're not doing handoffs from different providers for different services.
The one thing that I do think that will be a positive change is that the individuals will all be stationed at your office, and they'll be either seen by Maximus or the centers, and they won't have to go to various agencies. Is that correct?
Correct, that both providers will have a presence at Virgil Brown at our central office. That's correct.
Okay, so I have some questions. For this new RFP, will it consist of new work eligible individuals or previous individuals in the program?
It will consist of both. So the individuals who are currently on work participation will be brought over into the new contract, and individuals as they come in and come on board will be referred as well.
So the original participants didn't complete the program yet? Or
So
is
the
it
original-
something that they ever complete?
In trying to, if I don't answer the question, please let me know. To try to explain, anyone whose work required is work required and part of the program, as long as they're receiving benefits.
Gotcha.
So they have to be engaged with that with that particular provider. They have to be participating in their work activities in order to continue to maintain their eligibility. So that's why. So it's not that they complete. If they complete the program and get a job and placement, they're going to be tracked for the purposes of the success and the outcomes of the provider. And of the program as a whole, but they're not part of that work participation piece, which is the federal compliance piece. So we wouldn't refer anyone who had already been placed. It would be just people who have that work activity currently and are already receiving benefits, okay. And then new people as they come on board.
So that helps. So when these individuals are being tried to move to self-sufficiency,
yes,
with better jobs, are these jobs sustainable wage jobs?
That's the goal. That is the goal here. This is why we've placed incentives on these individuals achieving regular wages that are above the minimum wage. I think we put it at $2 and $4 above the minimum wage per hour. In addition, for jobs that come with health care, come with health insurance.
In 2014, there were 3,000 referrals, that according to the old RFP, with 2,000 individuals assigned to a work site within a year. What was the number of successful completion out of that 2,000?
You'll have to give me a minute. If I have it in front of me, if I give me 1 moment. I do not have 2014 data in front of me. I can certainly get that to you.
Okay. And what happens to the remaining participants who do not complete? What happens with that?
So for individuals, the only time that they suffer a consequence is if they don't meet the work participation. If they don't make their work participation, they are formally sanctioned and they lose their benefits. Okay. I would also add that one of the reasons that we want to go beyond that and put people in sustainable wage jobs and career paths is there's a time limit. There's a 36-month time limit as to how long you can receive benefits. So simply getting them into that work activity, into that meets that federal compliance piece, doesn't lead to long-term better outcomes.
Okay, and so they lose their benefits, and are they eligible since they didn't finish that work participation rate? And if they haven't used their 36 months, are they allowed to get back on?
Depends on the tier of sanction, but I mean, yes, it just depends on how long they have to wait before they can reapply.
And who sets that wait period time?
The Fed and the state.
Okay.
It's certainly not me. Just to throw that out there.
How many staff will need to be hired for this one-on-one provider? That is the current RFP. It states in there that their plan is to have one-on-one providers that will work with each individual work participant.
We do have representatives from Maximus and the senators here today. I would ask them to come up to answer these questions. Okay. They would.
Please state your name and which organization you're from.
Good evening. Name is Monty Starks. I'm with Maximus Project Manager.
To answer your question, the number of staff, we are looking at 20 individuals to be able to provide the services to the individuals enrolled in our program.
Okay, so is that an increase from the last RFP, because you were a provider at that time as well?
Correct. So that is an increase.
Okay, increase from what?
From 13 to 20. So
To 20-something or 20?
no, 13 to 20. 20. 20 staff.
All right, thank you, Monty.
You're welcome.
Hi, I'm Barb Randleman. I'm the Vice President of Workforce at the Centers for Families and Children.
I'll ask you the same question. What is there a staff increase with this new current contract? And if so, what was the number in the previous RFP, because you guys also participated? And I know it's then it wasn't.
It didn't
you weren't
include all the
subcontracting
services.
and all that. So
Right,
it'd be
it
a
didn't
different-
include all the services that we were providing.
Right.
So under this contract, there'd be 47 FTEs.
Okay.
I'm looking to my budget person. Compared to prior?
You have to go up and state your name.
I'm sorry.
Hi there.
Hi, Jill Dawson, the Centers for Families and Children. Prior to this, just the centers, we were at 18 FTE. So the centers alone is going from 18 to 27. As a whole coalition, we'll be at the 47.
Okay. But the 18, out of fairness to you guys, you were not doing all these services that are in now.
Correct.
Okay. Any questions for these two ladies from anyone? Okay, thank you. Kevin, what is the projected administrative cost for this new RFP compared to the old one? In percentages, I should be. I have the dollar amounts in front of us, but I wanted to know if it was outside of a 5% increase.
In terms of the administrative costs for the individual vendors, providers, I may have to get back to you on that unless. Yeah, I'm going to have to. I'll get back to you on that.
Okay. In your opinion, why does this contract amount is over double from the last contract?
Why does this deserve an increase and below which it does? Because we are asking them to take it from the start to the finish. We're asking them to shepherd these people in and get them into career paths. We're trying to not just meet the compliance, we're trying to drive better outcomes. We had services before that drove towards these as well, but we want to take a new approach to see if we can do better. And inherently that's going to require us to invest more money in this population. And I think it's worth it to invest more money in this population.
Okay, and my other issue was, I know these are TANF dollars, but can you explain to the committee why you should encumber all the TANF funds if it's just a pilot program and we do not actually have the numbers of the individuals? So why, for example, why wouldn't we just make this $3 million instead of $7 million?
I'll try to answer the question. I'm not sure if I understood.
So why are we encumbering the whole $7 million for this RFP if we don't have the numbers of participants to show us why we need $7 million? We don't have enough for, I mean, this is a pilot program.
We are going to refer all the TANF participants. I don't mean to imply, if I imply that, I apologize, that we're only going to take a portion of the participants. It's all of the participants in the TANF program who will be in this. And so we want to encumber that because we are providing for that population. And I don't mean to indicate, we are trying something new in terms of the model. The services are largely similar, but we're trying a different model in terms of getting them from start to finish. But it is the population. It is the entire population that we are serving.
And how many people are we serving?
How many people there are right now, and this is I have to sort of explain this. There are 670 individuals who are work required. That number changes on a monthly basis. And because we do sanction on a regular basis, there is a certain amount of, pardon the expression, churn to this. So that we will have 100 new people come on as 100 people come off because of their because of their failure to meet work activities. And so the population can be as high as 1,000 or more. The population can obviously sink down to 600. But it's more that people are coming in and people are failing to meet their activities. They go off, they come back on. It's a very fluid population.
And how many have we had to date? You said 670 are required, but how many have actually participated?
Actually meeting their work requirements. By last numbers, it is probably around 300 individuals. We're having trouble getting great reports out of the new system.
Okay, and because I still have the issue about the doubling. Yeah, I mean, you've explained it, it's not sticking with me. But I want to know, why is encumbrance of this contract and this amount of money, why is it different than the Board of Care and the Metro Health contracts, where we've kept them to only utilizing to the bare minimum of what they can show us they can use it for?
So, if this doesn't answer, I apologize. But the contract is aside. The bulk of the contract is based on them invoicing for actual cost that they incur to service the population, and then there is performance money based on whether they achieve the work participation rate, whether they achieve placements, and 90 and then 180-day retention. If they don't achieve those, they don't achieve that money, and if they don't incur the cost initially, and in terms of the amount of money they're spending to run the program, they won't obviously receive that. So the initial bill is based on the actual cost to run the program.
Are we paying incentives to these work participants?
So to the participants, no.
Yeah. No, okay.
No.
I want to open it up for questions. Councilman Miller, Councilwoman.
Madam Chair, Director, we've been talking about this program from our perspective of running this program, but I'd like to shift perspective for a moment and look from the perspective of one of the participants in the program, and from a participant's perspective, other than the fact that there will be a little more central coordination where you don't have to go chopping around to 5 different places to get services. Other than that centralization, what is going to be different in terms of what the participant actually sees in terms of the services that they receive?
I don't want to downplay that central coordination. That is the essential difference. The services provided are in fact similar. The central coordination is the big difference. With this population, relationships are important, and the relationship that they build with the vendor and these providers understand that, and they work to develop that relationship with these participants to bring them along and get them in those work activities and into those career paths. So that is the central difference, yes.
Madam Chair, Director, you'd think a centrally coordinated program would cost less money and not more money. You know, it's just simpler. There's not a going through intake 5 different times. There's not a telling your story 5 different times. There's not a lot of repetition. Why is a new program that provides basically the same set of services but in a centrally coordinated fashion, why does that cost twice as much per recipient than the current program?
I'm not sure that I will try and answer the question. With the central coordinated services, there is a little more overhead for the providers to provide that service, and to coordinate that. They obviously had to increase staff to do it. It is across 2 providers. There was a consistent element that we saw when we looked at proposals, that this was going to be an increase above and beyond the why. I could ask the providers to come back up and discuss that, but it was not something that was peculiar to these providers at all.
On a per year basis, what was the total cost of the old program and what will be the total cost of the new program?
As Councilman Conwell had stated earlier, it does double the program. It was to provide services that are covered by this contract was $3.5 million before annually. It is $7 million under this proposal.
And where does the additional money come from?
This money is TANF money. It's money that we have allocated to this program. We did not take from any other program to do so.
So, Madam Chair, Director, so did TANF provide us more money, or you know, if we're not cutting anything else out and we're adding 3.5 million a year, it seems like TANF is providing us more money so we can do that. Is that the case?
I think that more of the cases that we often leave TANF money on the table, in that it can only be used for certain activities. Obviously, providing it's primarily geared towards the work required, or pardon me, the cash population, and so oftentimes the money is left on the table at the state level, and so year after year we find that there is TANF money left on the table, and that is how I would explain that.
Madam Chair, Director, I would ask if either of the providers could provide us any insight on why the centrally coordinated program costs twice as much per recipient.
Good evening once again. Monty Starks with Maximus Project Manager. I would say Maximus costs increased slightly because of the services that we're now providing. We're bringing in the staff, the FTEs, and innovative technology to align with the additional services that we're providing. These services will then be able to align with the individuals that help them become employable within the county. So that is where our cost has increased, focus on the FTEs and the various innovative technologies we're bringing in to streamline the whole process and to make it less daunting for the individuals which we serve.
Can you share some of those innovative?
Sure. So one of the ones is for employ. This is our job search, job readiness mechanism where individuals will come in, do job search. What's unique about this particular product, it centralizes everything for the individual. The traditional way of job search is when individuals go out and they are constantly going out manually looking for jobs. This is more like a one-stop shop for the individuals. They can do everything within this application. They could search for jobs, it stores jobs, they can submit resumes within this application, and it's there. The most important thing is it's done in real time, where staff can track it and provide innovative actions or engage the individuals if they're stuck during that process. Additionally, employer provides the necessary tools. So if an individual is searching for a job and they want to get more information on, before I submit my resume for this mechanical job, employee would then allow them to get one-on-one coaching with individuals in real time to provide additional information on what they need to make sure they have on their resume, to give some pointers on how to do mock interviews, what questions to look for. So all of these are interactive and it's real time. So this is one of the innovative projects that we're bringing to the table to be able to assist our individuals find employment.
So I'd like to put forward a theory that that under the old system, since the services were scattered among a number of providers, that the providing of services was kind of hit or miss, and that the typical client, typical participant would get this service or that service, but not this other, not some other services, and that most of the clients were only getting some of the services, were under the new system, because it's centrally coordinated. You're going to make sure that each participant gets all the services they need in a coordinated fashion, so typically each participant is going to get more services than they did under the prior model. My question is, do you agree with that assessment?
From the maximum standpoint, yes, we agree with that assessment.
As the centers, what us and our partners went together to do is we assumed on this that this contract was bringing together the previous job readiness, job placement, the job skills, the ICM, the WEP, and the ABOD population. So the centers and our partners developed a budget based on us serving 1,500 individuals coming to our door. So that is the assumptions that we developed our budget from, and I think that's a point that needs clarified.
So, Madam Chair, what's your name again, please?
Jill Dawson.
To Ms. Dawson, am I hearing you saying that that for you the number of people served is not going to be the same, that you're going to serve more people under the new program?
That was the assumption of how we developed the program and how we developed the budgets.
Okay.
Councilwoman Brown?
Thank you, Madam Chair. As it relates to this employee, is this a software that both of you utilize, or is it exclusive to?
It's exclusive to Maximus. This is Maximus product. It's a Maximus product.
Okay. So the centers, do you have a complementary product?
Yes.
We will be using Salesforce, which is a common application.
Okay, with regards to these software programs, are they exclusive to our network of employers, if you will, or is it broad? How does it differentiate from Indeed or another?
I don't want to speak for Maximus, but we'll be using as our client database so that we can track our clients across all of their work activities, working to address their barriers, following their job leads, whether they've completed compliance with all the things that they are required to comply with. So that's our internal system for managing our clients in their journey across their work activities.
So in addition to their journey, though, if I understood correctly, they have an opportunity to upload resumes and make applications. So it's not, does it limit them to a specific labor force is what I'm trying to get clarity on, or?
Is that in your system? That's not in.
Oh, okay.
To answer your question, no. Employ pulls information from all of the major search engines out there on the internet and also local. We also have the ability to manually enter employers that we develop our own in the community. And additionally, it pulls information from not just Cleveland, Ohio, all of Ohio, and all of the United States. So if individuals here and they find something in Columbus, Ohio, they can have the opportunity to actually submit their resume and apply for that position through our system and move forward from there.
Okay, with regards to the metrics and measurements relative, we just learned that now that the number is going to be increased as population served. What do we as the county have in place to ensure what is a success of this program is what I'm trying to figure out. What minimums are in place?
Okay, so if I make sure I address the question. So, in order to measure the success of the program, we're going to look at the number of individuals referred, and then we have set guidelines as to what's an acceptable the number of people who are job ready, and acceptable number of people who are placed, and acceptable number of people who are meeting their work requirements. So those are all built in the contracts, and those outcome measures are the same for both providers. Okay. I think the other question is, how are we going to guarantee that the people are being referred to them? We have a division in our work participation area that is going to refer them out to them. We are also at a large extent dependent upon the population. So right now it's at 674 people are currently work required. However, as I said, this is kind of a churn population. It's sometimes hard to get your hand around. We're going to continue to monitor them. And we're going to look at, are we keeping up with our workload so that those referrals are getting there in a timely manner? We as an agency, that's our performance measure. We need to get these done in a timely manner so that we meet our work activity rates and we get these people to services immediately.
And so the $10, if I understand, they are reimbursed to us. This does not come out of HHS or our general fund.
Correct. It's TANF money.
Okay. And we talked about the rate as far as them having a living wage is what we sometimes refer to it as. Yes. And that being at least $2 above the minimum wage.
Minimum wage.
So is there a subsidy relative? Do we provide that? If there's a job, is there a subsidy, a $2 subsidy, or is just
that you have placed them in a job that is $2 above the minimum wage. And then there's a further incentive for $4 above the minimum wage.
Okay, so as far as all of the incentive and metrics and minimum requirements are concerned, those must be fulfilled in order to receive our reimbursement from the federal government.
Those, let me make sure I understand what you're asking. So those incentives around the living wage, those are not necessary.
No, I'm sorry. I changed subjects. I'm sorry. So relative to the success rate and what looks like success to the county, is that mirrored or just come from what those standards are from the federal government? Is that?
So the numbers that I gave you in terms of 70% placement, that's what you're asking.
Right.
That is not something that is set by the federal government. The only thing set by the federal government is the work participation rate.
Can you elaborate?
Sure. The work participation rate is 50%. It is 60% for these providers. We set the bar a little higher.
Okay, so if we just round that number down to 600, you would want a 360 participation rate.
Yes.
And the
if the population were to stay the same, and which it doesn't, but yes, if we were looking at current thing, correct.
Okay, thank you, Madam Chair.
Madam Chair.
Councilman Miller.
Just one other basic question. Can you refresh my memory as to how long this contract is for?
This contract is for 12 months.
And are there renewal options?
There are. There are two renewal options.
Two one-year options?
Yes.
Okay, fine. Okay, thank you.
But as I
It's on
recall.
a pretty short leash.
Right, but as I recall, it is, the funds would be encumbered for 3 years, not a year. It would be.
Yes, I believe that's correct. Right. I'll double check.
So it would be, the funds would be put aside for 3 years instead of that 1 year by it being a pilot.
Wait, no, David's going to step in.
There we go.
Sorry. David Merriman, Health and Human Services. The funds will be encumbered for 1 year. Yeah. We only encumber funds 1 year at a time.
Thank you.
All right. No, you're good? Okay. So I know that Director Gowan was when me and him had a conversation about this contract, he would be willing to do a year. Since it is a pilot and things of that nature, because I do not want to encumber anything for 3 years. I'm willing to go for the year. But my suggestion would be for that, and haven't heard from my colleagues yet, would be that in 8 months that you could come back. I think that would give you enough time to present to this committee. That's, me and Levine looked at it. It's February 2020. Can't tell you the date. I think she said February 20th. We looked it up. If you could come back and give us a full presentation of how the program is going, that would be sort of my compromise. But I'd like to hear from each of my colleagues and their feelings.
We'd be happy to do that, but.
Madam Chair, I think what you're suggesting makes sense, that we want to have the administration come in and give us a full report on how this program is doing early enough so that if we feel we need to make a change of direction, we'll have time to put that in motion before the first year expires. Thank you.
Thank you. Councilman Jones?
I echo that sentiment.
Councilwoman Brown?
Thank you, Madam Chair. I think, given the introduction of the idea that this is going to serve more people makes it more palatable, but I do express and share the same concerns as you and Councilman Miller with having doubled the budget and not doubling the results or anticipated goals. And I guess if you can demonstrate that success to us in the future meeting, that would certainly be helpful. So I echo my colleague's sentiment, although I do appreciate learning that you will increase the reach. And I do understand that there's also added costs because you've increased your number of employees, but we should hope that that would yield, if not reaching more people, at least better results. So that's what I'll be looking for.
That's what I'm
if
looking
not
for
more
as well.
people, definitely a much higher success rate than 60%.
Thank
Madam
you.
Chair, are we prepared to only give them a portion of this funding and then allow them to come back? Because I don't see a reason to go to the full amount. I'd be prepared to amend what they receive to a partial, which gives them an added reason to produce, because if you don't produce, you don't get the second piece of the money.
And that was my understanding, that I thought the contract was written up that way, that it said it would encumber that $3 million totally. So I will be checking those facts. So that was my assumption. And so I was prepared to amend the legislation for it to just go for a year, but we will check and make sure that.
Not only for the year, but to reduce the dollar amount until they've proved themselves.
Well, I believe the $7 million is for the total 3 years,
The
correct?
total possible value of the contract, yes.
Right, so I will be
Contracts.
checking with our staff to make sure that what they stated here on the in front of us is true, is that it's written up that it's for a year and then with the option of 2. I know I think it says something different, but we will check. And so if it isn't written up that way, then we're going to have to amend it for just a year.
Okay.
But if it's not, it will stay. And it's on agenda. We will get the amendment out. We have plenty of time to get the amendment out, but I'm sure my fact checkers will be checking that.
I believe they'll be satisfied, but we welcome any questions.
And
Yes.
we'll definitely let Walter know and you know right away. Okay, any other questions? I just had one for Monty in terms of, did I say that right?
Yes.
You talked about your employee mechanism as sort of a one-stop shop. How does that relate with Ohio Means Jobs? Because they're they kind of went from, I forget what they were called before. They were considered a one-stop shop in terms of jobs.
I would say, let me clarify, when I say one-stop shop, I'm speaking of the application itself where individuals can utilize and do everything within that system.
Okay.
Where they're automatically going in, they're searching their jobs there, they're not going, visiting 20 different places. At the same time, while they're sitting there, they can also get additional resource and tools or training to help them and aid them while they're doing that, going through that journey of doing job search.
Are they using your own computers or the ones that are stationed down at Virgil Brown already?
What's unique about this application is it's mobile, so they have the option of going at home and utilizing it. They can utilize it through their phone, they can utilize it through their laptop, or they can utilize the resource center or any computer that's connected to the internet. They have access to our system, so it makes it much more viable for them to do it anywhere they are.
Okay, so when we talk about career placement, I know there's no guarantees that these individuals will get jobs, but what connection does that career placement go with Ohio Means Jobs? Are you coordinating any type of services, or because that's where the majority of us send people to look for jobs?
I do not have a specific answer for that, but that's something I will look into and get back to you. I'll relay that back to Kevin to give you a better.
Hi, Barbara Edelman. So I wanted to stress that the program provides all services from helping barrier removals through job training, through job placement, job search, and then retention after they get a job to ensure their continued success and movement along a career path. So clients aren't coming to us just for a job placement. That doesn't tend to have very good outcomes. So our focus is on giving them, in 4 to 6 weeks, giving them the job-ready skills, the barrier removal, the tools that they need to find a job that's a good fit and that they can succeed in and imagine themselves growing in their career, and then we're going to stick with them. We're providing these services to all of the clients, even those who didn't previously have work requirements. So it's a bigger group, and yet we're confident that we can have successful outcomes across the different groups of populations. So so you can imagine someone starting a journey and being matched with someone who we're calling them a navigator, who's going to be with them throughout that journey to ensure that they're not bopping back and forth in and out of the program, going out of compliance. We're going to ensure their continued engagement to try to reduce the chances that they fall out of compliance, and inspire them to have a goal to move along a career path. And then we are going to provide those supports, retention after placement, to ensure that they continue to have barrier removal and support, so that they can have, this is going to be life-changing for the candidates and then also for their families. So it's a much bigger program than just, one-stop shop where they're just being referred to for a job search. They're actually getting trained for job success.
And I get that, and I know we can belabor this forever, but my concern is the individuals that we're working with to get the soft skills that are needed while required to keep their benefits, so to speak. We get them to a point, we get them a job, and I'm hoping that these will be sustainable jobs, because then we're weeding them off of benefits. Because my concern is the way the federal government is set up, these individuals cannot partake in education to further their education while utilizing benefits. They're not allowed, they can use these workforce training components, but they're not allowed to use education at a college or something like that to further.
To that point, I'll add that we have included money to be able to send our clients who are interested for further educational attainment or vocational education. We think that's a really important thing that, for some people, most of the people, probably a job will be something they will want to do, pursue a career path, but we want to enable them to further their educational attainment as well.
Thank you. Thank you for that. And I'm going to.
Sorry, just one step. Maximus mirrors the same model.
Okay, I'm gonna write that on there.
And I just wanted to bring to a point, the centers last year served over 600 individuals in our job skills center and almost 400 individuals in our job readiness, job placement. So there alone, the centers touched almost 1,000 individuals with this contract. So we are looking at serving potentially 1,500 in the next contract. And the contract is set up to be 70% cost reimbursement and 30% fee for service. So if we don't perform, we do actually have the opportunity to lose money on this contract. So there is the built-in incentives for us to be able, because we get paid every time we meet our hours, they get placed, they're on a job for 90 days, and they're on a job for 180. So if we don't successfully complete the outcomes in this contract, we will not achieve the whole amount. So it was really set to incentivize us to get the outcomes that the county is looking for.
Yes, Councilwoman.
On that point, so if we happen to underutilize these dollars, where do they go? Then what happens to them?
They go back to the state essentially. If we don't, unless we have another TANF use for them, we'd have to unencumber them and then use them in another fashion. But we would lose out on that money.
And these are strictly TANF. I could be confusing my meetings, but there's no collaboration with WIOA relative to this program, or is there?
Yeah, so referring to OMJ and the WIOA program, we do work with OMJ. The problem that we run with this particular population is that this population often doesn't meet the requirements to be in a WIOA program, and that we often are looking at people who need to get their GED and who have little to no work history. And the WIOA program originally was set up as a displaced worker program, whereas the people in this program need to develop a work history and build a work history, and they're starting out at a lower point on the ladder. So.
Okay, so no WIOA collaboration is what I'm trying to
So
say.
the individual centers, I don't know that. Yes, wait, here we go.
Council, Lisa Evans, Verge, one of the partners with the centers. When they come in and do intake, they're immediately connected with OMJ. That's part of our intake and assessment process. We also look at their educational goals. So we do a lot of upfront assessment to make sure that we're actually putting them in the correct program, so they're not just going from different places. Once we do that, as Barbara indicated, they're connected with a navigator. So we're not just sending them somewhere. They'll actually have a partner to help them navigate computer programs, OMJ, to make sure they're actually getting the services so that they don't just quit because they don't get an answer.
Okay, thank you. I'm sorry, because I know Councilwoman Conway.
Oh, no, that's fine. And I just want the committee to be aware that even though it is kind of leading that TANF dollars are just for this workforce training, there are other uses that HHS can use them for administrative costs. I have covered that basis with Walter, so I don't want you to leave and think that they're just for workforce training. And if Monty and Barbara could leave your numbers with the clerk if we have any further questions, I'd appreciate it. Anything else you guys would like to share? Nope, hearing none. No miscellaneous business. This meeting is adjourned.